All right, perfect. So I think one of my panelists is running a bit behind, but we are just going to keep going. And again, I'm so excited to see all of you here as we have this conversation on cultural competency in the context of HIV service delivery. I'd like to first, of course, welcome all of you, but introduce our special guests who will be serving as panelists. So first I have Ms. Tamika English, who is the Source Leadership Program Manager for Sister Love, which is an Atlanta-based nonprofit. And I'm just going to ask if everyone could mute if you're not talking, just because I'm hearing a bit of interference. Thank you. So Ms. English is the Source Leadership Program Manager for Sister Love, which is an Atlanta-based nonprofit, part of the Community Capacity Project, as each of the organizations represented on the panel. And they work in support of sexual and reproductive health rights, as well as HIV prevention for women both in Georgia, primarily in Atlanta, and internationally. So welcome, Ms. English. Thank you for joining us. I also have Dr. Sibley Strader, bilingual staff physician, and Dr. Tamoor Rashid, community health program manager and QI analyst at Asian Services in Action, or ASIA as the acronym goes, a nonprofit providing clinical and social support embedded in culturally informed service delivery, primarily for the Asian American and Pacific Islander community based in Ohio, both with locations in Akron and Cleveland. So thank you both for joining us. I'm just admitting a few people here. All right, so joining us now, I have Mr. Luis Lira, who is the PrEP Care Coordinator for Esperanza, which is a network of health centers which provide clinical care and support for the underserved communities in Chicago. So welcome, Mr. Lira. Thank you for joining us. And last but certainly not least, I have Greg Wilson, Senior Manager at In the Meantime, a Los Angeles-based nonprofit who you've probably read about in our last newsletter, working to improve physical and mental health of intergenerational Black men, including those at risk of HIV. So, Mr. Wilson, thank you as well for joining us. And I'm just letting a few more people in. So just a bit of housekeeping. Please mute if you're not currently actively speaking. Reminder that we are recording this event, especially for those who have just joined us. And please use the chat for any questions that you may have. We will have a Q&A towards the end of this. So we welcome any questions, anything that you may think of in the midst of panelists answering these upcoming questions. Feel free to add them there, and I can certainly facilitate that towards the end of the event. If you'd like to wait and ask directly, feel free to raise your hand during that portion of the event. And so I'd like to also ask that our panelists keep any responses to a maximum of 2 minutes, just with respect to time. And with that said, I think we can get started. So this will be sort of a roundtable. I will just ask individual panelists to answer these questions. Each of these questions are for everyone. So I'd like to begin with first kind of setting the stage, or setting the scene, I should say, with which communities do your organizations work with, and how has your organization engaged them, specifically in HIV self-testing? And Dr. Strader, I'll begin with you.
Unmute. Okay. Hi, I'm Dr. Strader. I work in Asia and it's Health Clinic ICHC. We're located in Cleveland and Akron in the great state of Ohio. We serve the underserved patients, including immigrants, refugees, humanitarian parolees, and their children. The majority of our community members come from countries in Asia and Africa, including, but not limited to, China, Taiwan, Nepal, Bhutan, Myanmar, Thailand, Congo, and most recently, Afghanistan. In the clinic setting, discussing HIV self-testing is more natural. For me, I recommend universal testing to all my patients from 13 and up. And I also encourage them to take advantage of the free self-test kits offered by Dr. Rashid in my organization. And also, I recommend them to take to take the advantage of the free self-test kits from our community partners in all of Greater Cleveland and Akron area. And Espinosa is actually one of them.
Thank you, Dr. Rashid. If there's anything you'd like to add to that.
Sure. Yeah, basically what she said, we serve primarily the AAPI, immigrant refugee community members here. Most are low income, low literacy, limited English proficient community members. And so this provides a lot of challenges for us. I work very closely with our comms specialist here at Asia to come up with messaging around HIV, messaging that's clear, concise, easy to understand, easy to read, and oftentimes translated into the many number of languages that our community members speak in our community. So we have a translation services department that does all the translating for us. Most of our CHWs are also bilingual, and so that really helps with engaging and building trust and rapport with our community members where they're at in their respective communities.
Thank you. Mr. Wilson.
Hello, everyone. My name is Greg Wilson, and I work for In the Meantime Men's Group, Inc., based here in Los Angeles. Our demographic that we reach is usually intergenerational Black gay men. But for this specific project, we are gearing it towards Black gay men ages 18 through 29 years old. And we like to call this particular project You Test You. And we're really excited about being able to provide access through our storefront testing and also our mobile testing unit. We have a mobile testing unit that we utilize. So those are the ways that we've been able to engage our population with HIV self-testing.
Thank you so much. Mr. Lira?
Hi, my name is Louis Lira. I'm the community health advocate at Esperanza Health Centers. And our target population is anyone in the southwest of Chicago who feel they're at risk for HIV. So that includes LGBT and also heterosexual communities. For the program for PrEP, and also we provide HIV services like HIV treatment and HIV support groups.
Thank you. And Miss English for Sister Love.
Absolutely. Tamika English again. Thank you so much for having me. I represent Sister Love, and we're based here in Atlanta, Georgia. We have what we consider our EPs, or our essential populations. And that obviously, like some of my partner organizations here, includes LGBTQ+. Obviously, we like to engage the youth on purpose. But we have this belief here at Sister Love that if we focus in on the women, and make them our primary essential population, then what happens in turn is they bring us their partners, they bring us their sons, they bring us their daughters, they bring us their children, their neighbors, and all the people that they care for. So essentially, we end up serving the entire community by centering the woman, the Black woman to be specific. And obviously, we're concerned with the woman in all of her diversity. But we find something very special about centering the Black woman, because she tends to bring the entire community with her. And that's who we serve. We offer free HIV and STI screening in the community in the Atlanta area, and we just recently got a bus, so we're hoping to be able to reach those folks in the more rural spaces in Georgia that don't necessarily have access to these free services. We are looking at the underserved, the undocumented, all of those folks that have a lot of barriers to going into your traditional clinical settings to get these screenings, and we make it as easy as possible for them to come through our doors.
Thank you so much. This is already so inspiring. So the next question I actually have is, based on cultural competency and suppose the nuances, what are some core contextual understandings that your staff must have when engaging with the minority populations that you've mentioned to seek your services? And how would you tailor support to each of your respective communities? Ms. English, I'll actually start with you.
Awesome. So we have this thing at Sister Love where we don't just say, but we put into practice where we meet folks where they're at. So we're consistently looking at our intake processes, the way we question people, the questions that we ask when they come in their doors, what's required and what's not required. We're consistently looking at that to see how, even in our blind spots, we might be marginalizing folks, and we do the very thing to fix it. So as an example, we don't require anyone to have an ID. When they come through our doors. We're not asking them about a physical home address or a phone number, if you will. Now, obviously, if they're willing to share these things for us to engage them further beyond that appointment, we're wanting to do that, but we're not wanting to marginalize those who may have a difficult time coming up with a home address or an ID, if you will. And those are just some very, very small examples. We also want to make sure that the language is universal. So when we're talking to people about their behaviors, we've removed the language risk from our assessments because we don't want to turn people off with the paradigm of risk. So we're asking them about their behaviors and their pleasures. And we found that when we were doing that, perhaps it was leaning a bit to the heteronormative side. So we went in and fixed that to make sure that we were using inclusive language so that we were, making sure that there's space for our trans and non-binary individuals when they come through our doors. So those are just some of the small examples that we're doing to make sure that we're showing up to meet folks where they're at.
Thank you. Yes, inclusive language, incredibly important and powerful. So I appreciate that. Thank you. Mr. Wilson.
Yes. Thank you. Yes, I'll start by saying we're fortunate to have our staff our staff is comprised of being a part of the demographic that we serve. I like to say that, we have Black gay men that actually are serving Black gay men. So we really not have our own lived experience and understanding to where we can actually relate to the populations that we're serving. I would also say that engagement truly goes beyond what we may read or hear. So I think it's really important that we allow the participants to really be the experts of their own experience. So it's really important that we listen. It's imperative that we listen. And I think those are some of the contextual things that we find that works. Because of course, we can't assume anything. We have to understand what they're saying by allowing them to say it. So I think it starts with us having staff that is relatable to the population. It's important that we make sure we listen to what they are saying that they need, because of course they're the experts of their experience. And also for us not to assume that we know better than they do about their own needs. And I think those are the core things that we need to be able to do, to really do the work that we're doing. And then also, meeting them where they are is key as well. So when it comes down to how we tailor the support for the individuals, it is really meeting them where they are and understanding that, it's going to be different for each person.
Thank you so much. Mr. Lira.
Yes, I'm sorry. The question again?
Oh, not a problem. So the question is, what are some core contextual understandings that your staff must have when engaging with minority populations, those that you've mentioned, to seek your services? And then how would you sort of tailor that support to these communities?
Okay. Well, we are community health-based health centers. So our staff is all bilingual. So that's a plus, since we're working with like 80% is immigrant population that comes to our clinics. And so that's core for us, for them to speak both English and Spanish. But also, we have sensitivity trainings for all staff, including from the front desk all the way to to the phlebotomist. So they learn about what HIV/AIDS is, and also like how to collect data, and like when they register them, make sure that we get their names and their pronouns, the correct terms that they prefer to use, and And also through our program, our first encounter is in private, it's in an office. So that helps a lot because if they're in the front desk, everybody can hear them. So it's much easier to collect data that way. We do a risk health assessment where we ask not just risk questions, but also like how often you get tested, what was your last HIV result, any history of STIs. And we also ask about their partners, like tell me something that you worry about your partner. Is your partner HIV positive? Does he inject drugs? Did he exchange sex for money? Things like that. And we use a lot of open-ended questions. That way we can get a lot of more information at when we enroll people for PrEP. It has happened where sometimes they're seeking HIV treatment, but they say they're coming for PrEP. And that's totally fine because we have an HIV program. But you know, people sometimes they need time to trust. And so we always keep an open door, make sure that they have our contact information. They don't have to call the calling center to get a service. They can call directly to us. And they don't have to explain themselves when they come in.
Thank you. And you mentioned trust. I will be bringing that back up momentarily because that's incredibly important. And I love how you mentioned inclusivity training or sensitivity training to the entire staff from one end of the spectrum to the other. And that's very, very important. So thank you very much for sharing that. Dr. Rashid.
Yeah, so I think, piggybacking off of basically what everyone here has been saying so far, I think it starts with our staff and what we kind of project as an organization outwardly and the response that elicits from the community, and us maintaining generally a safe space where we can normalize conversations in general, conversations about sexual health, conversations about HIV and testing and the importance of testing and general awareness of what it is. And I think it does start with our staff. I also think that again, trust is huge, and kind of the reason why community members come to us is because they don't really have anywhere else to go to because they're limited English proficient, they're low literacy. We provide all of those services for them in order for them to, live their best life, basically. And so they come to us for a reason, and there's a lot of trust that they have with us for that reason, with our providers like Dr. Strader, our MAs, our support staff. And so we have a pretty solid dynamic with our patients, our community members in general. And I think it also goes back to our staff coming from the same communities as our patients whom we serve, which is, again, huge for building rapport and trust. So.
Absolutely. Thank you. Dr. Strader, is there anything you'd like to add?
Yes, I feel like Mr. Lira and our clinic are very similar, and he is right. Language is a big key. So I think we're trying to move away from cultural competency, like admitting we don't know a lot, and moving towards cultural humility. Like everybody's culture is important, and it is our responsibility to learn. And in our clinic, all our providers, I think 85% of our providers speaks a second language, the language that our patient speaks. And within our clinic has the capacity to provide like 55 different languages. All our providers have some degree in training and working with an interpreter. Asia even have a program called Breaking Down Barrier, where we learn to convey our thoughts, both verbal and nonverbal, towards the patients, and to how to watch the patients heal and to show the patients that we really care about them and we're really listening, which our panelists are all rock star at. I also feel very lucky. Dr. Rashid says, starting from the staff up, we have a very supportive, I call command staff. So our leadership from the top, they are very vested in changing our culture. And when we first started the huge undertaking to eradicate HIV in our patient population, we know that just learning the LGBTQ culture, the statistic and the terminology, the pronouns, those are really important, but it's not enough. We're not just learning about new culture and concept. We want to change our clinic culture or our organization culture so we are inclusive and we are welcoming. Our CEO, Elaine, she doesn't just set up the training. She gives all our staff time off. She literally closed the clinic and the whole organization just so we can take this class. And we don't just learn facts. We are asked to do exercise and we do role play. We learn to walk in our patient's shoes and imagine what it's like to have to face some of the challenge and obstacles that our patients face. And that, I think, make a difference. And like Dr. Rashid said, all those little things like color condoms in the room, welcome flag in the lobby, our social media showing flags or allies emblem, right bathroom signs and private rooms, ensuring patients have confidentiality. Those are all that we do to try to make it a welcoming place for our patients.
Thank you. And I appreciate the insight into the training that your organization does. That's really helpful to hear, especially for other organizations that are coordinating their own trainings and elements of sort of cultural competency, cultural humility training. And so you mentioned cultural humility, and that leads me into my next question, with the understanding that cultural competency is not an absolute, as cultural and societal norms are constantly shifting within communities. And so my question for all of you is, how has your organization continued to improve its cultural competency or humility over the years, and what skills beyond the ones you've mentioned have been helpful for your staff to continue to improve their cultural engagement in the context of continually improving? And again, I know that this has been mentioned in passing in some of the responses, but if you could elaborate a bit more. And Mr. Wilson, I saw you nodding, so I'm going to you first.
Thank you. I appreciate it. I would have to say one thing that we've done is we make sure our team stayed abreast of different trainings that are offered. But not only that, but my executive director, Jeffrey King, and myself, we've actually been instrumental with the Department of Public Health's LA County Commission on HIV. And basically there was culturally competency trainings that were developed through the Commission on HIV, and we were able to contribute and add based on the things that we've not only heard, experienced, and know. And I think that has been something that's really helped to improve cultural competency in LA County altogether, for one. But second thing is we've actually utilized our community advisory board. And I think that the fact that we really incorporate them in most of the decision-making and a lot of the ideas that come about, we're able to really make sure that we are in tune with the different cultures and different changes and shifts that are happening with their population, because of course they're having access to their networks and peers that we may not have access to. So I think that has really helped us remain evolved in regards to cultural competency, and also it has helped us with informing community and other organizations that are reaching the population that we represent and serve. And I think that really by us being present and available to assist with that, I think that's really been helping to build everything in regards to cultural competency.
Thank you. Mr. Lira.
Yes, I think something that has helped is we had a public transportation campaign where we had people that look like us, talking about PrEP and testing and STD screening. So that has helped. It's very important to have marketing materials as well, not just the staff, but also, have collaborations with community members. We collaborate with different agencies. They see different subpopulations in the community, and we go and provide HIV and prevention information right on site. And sometimes we do rapid testing as well as take-home testing right at their sites. And that has been very helpful because we have people that actually say, oh, we know Louis at Esperanza Health Center, and he has like free HIV testing kits, or we know Louis, and right there, he'll help you get like coverage for PrEP, or to hook you up with an HIV specialist. So that's been helpful, like having members of the community that know you, and also who can batch for you with people who may be having a hard time trusting the health system.
Absolutely. Absolutely. Thank you. Dr. Rashid.
Yeah, going off of what Dr. Strader was saying, our CEO, Elaine, has been, and Dr. Strader have been instrumental in getting our training sessions scheduled for our organization, choosing the right one, ensuring that time is blocked off for all of the staff to actively participate in these training sessions. I think it also, honestly, I think it's the organizational change, organizational shift that's been taking place, making sure, or having a genuine openness from the leadership in our organization to implement small changes here and there that ultimately add up to creating an environment that's conducive and inclusive. An environment that normalizes talk about around sexual health, or around HIV, anything really, in our organization, health related, social related. Our leadership has been instrumental in, and continues to be instrumental in creating positive change for our organization, and that ultimately benefits the community.
Thank you. And I'm hearing a trend here of being amenable and flexible to changes that need to be made in response to how the communities are shifting. So I'm hearing that so far in our responses. Dr. Strader, is there anything you'd like to add?
I hope the rain is not too loud. So the contextual understanding from our staff, I think for me, basic knowledge about the patient's country or town of origin is very helpful. Like the patient, my patients or the clients' geography, language, festivals. So if anybody is celebrating Diwali, happy Diwali, and religion, diet, belief regarding wellness and disease. But those little things are helpful. But most importantly, I do need to find time to learn my patient's story. Even in very similar environments, like they are running for their lives in the jungle or living in a cramped area in a refugee camp, they may perceive their experience differently. And knowing what they've gone through and how it changed them as a person can teach me how to serve them better. And to find ways to support my community. Similar to what Louis says, we enlist help from our community members. Asia and ICHC, we have a very close connection with our community. Most of our staff are from the community we serve, and they speak their native language, and they are themselves refugees or immigrants or children of refugees and immigrants. So we ask our local pharmacists and the polypharmacists, the elders in the temple and the churches and the organizers of the local nonprofits what they need. Asia do our best to provide the basic needs like food, shelter, transportations, access to health and healthcare. But for everything else, we try not to project the needs on them. We ask them what we can do for them, and we do our best to fulfill those needs.
Thank you. And you mentioned something paramount here, which is ensuring that patients feel seen, that their experiences are heard, and that is absolutely necessary to efficient engagement, both in the community and with individual patients. So thank you for that. Ms. English.
Thank you. So as it relates to improving our cultural competency over the years, I would say in general that we've been recently training our staff in the areas of trauma-informed and harm reduction approaches, so that we are being present for the stories of people and finding the value of really intentionally listening to those stories to then decide what the best approach or intervention might be based on what they've explained they need from where they are. So we've been doing that form of training. And also because our work is women-centered, we've wanted to go back and reinforce our commitment to the entire community, specifically the LGBTQ plus community, with a special emphasis on the T, you see, because trans women want to know that they are included, and by God, they are. Even trans men have a place at our table, you see, because they were assigned female at birth, and there are certain accesses to healthcare services that they need that is of interest to us as women, you see. And so just making sure that when we say in all our diversity, that we're really showing up in that way and doing so in the way that we're approaching the community.
Thank you. Showing up. Absolutely. Thank you very much for that answer. So another question I have, again, for all of you, would be what barriers to engaging your communities in HIV testing have you found in the particular communities, again, that you've mentioned? And then on the positive end, so it's a two-part question, what are the facilitators that you found to effectively getting people to serve in HIV testing, HIV care? And Mr. Lira, I'll start with you.
Sure, I think that the biggest barrier is the stigma in the Latino community about HIV and all the stereotypes that are played within the community and within even the health system sometimes. So that's why I spend most of my time educating not just the community, but also like peers and other members of our clinic and our community leaders too, so they can spread the voice. I think the stigma is the biggest barrier that I have. And then the other one is some cultural differences between Latinos and others that a lot of them do not believe that about illness, that if you feel fine, that means that everything's okay and you don't have to do anything about it. Usually, sometimes they wait until they don't believe so much in preventive medicine, they wait till they're ill. So they end up in the ER or in the emergency room. So kind of changing that train of thought, what people think that, going to a clinic, going to a doctor, going to a hospital is only like to treat something instead of maybe trying to prevent something. So that's those are the two biggest barriers, some cultural things that are in the community, and also the stigma that has been built around HIV and PrEP. Yeah. So with all in that, in the middle is testing. So it all relates. Like, I get a lot of responses, like some patients tell me, oh, I don't have sex like that, so I don't need to get tested, or I really haven't done anything risky. And then when you start asking more and more and more, maybe they haven't done like anal sex, but they had done a lot of oral sex or other things that can put them at risk. So kind of like keep the conversation going has helped for me. But it is a barrier that there's a lot of stigma around, like who should get tested, who can get HIV. And the thing about the cultural difference that they think that you go to the doctor when you're sick, and not for preventive services. So, yeah.
Thank you for that. And it seems like a facilitator then is improving sexual health education. Yes, thank you so much. Mr. Wilson.
Okay, thank you. I want to start by expressing some of the pros, and then I'll go into the barrier. I think some of the benefits that we've noticed in regards to HIV testing, especially with the home test kits, was the fact that we have been able to offer to our community a lot of different options. I think the fact that, you know, sometimes people will come in with their partners and their partners might be apprehensive, or their friends or sexual partners might be apprehensive. So it gives them the option to really be able to have another way of engaging somebody and getting their, understanding their status. What we've also found is that it's helped to empower a lot of the participants in feeling that they can educate their peers as well, because a lot of times they get information from us and they want to go home and go to their friends and their networks and share the information that they've learned. So I think that by having the home test kits and this particular initiative has really helped them to become empowered, to educate their peers, and also to really know that there's additional options for them as well. I think when it comes down to well, another thing I'll say, you know, I keep mentioning mobile testing. I know that it's something that I really am glad that we are able to offer. We're able to go into the community, be innovative in our approaches with our outreach, and in how we really engage. But I would say when it comes to a barrier, the one barrier that we did have to come across and kind of readjust based around was the COVID, of course, because a lot of people were not going out into the communities. A lot of people were shutting down places. So when it came down to us being as innovative, we had to really get creative in how we constructed our in-house testing, and as opposed to being able to go out to community the way we used to. So that was one of the biggest barriers, is really adjusting and evolving around the whole COVID pandemic, and understanding how we can still make sure we reach people and meet them where they are. But that had to be the one barrier, but more benefits than barriers is what we've identified.
Thank you very much. Ms. English.
Yeah, like totally feeling that, Greg, because but prior to COVID, Sister Love didn't have necessarily like an at-home testing telehealth type of platform. It was because of COVID that we had to hurry up and update our systems and get ourselves prepared to engage the environment or the community from a digital space. That's when we first started sending those at-home test kits out. And obviously it was of interest to us to be available for those folks on the other end when they receive those test kits, to have someone to talk them through. So that's why we implemented the telehealth. And honestly, y'all, it was of a transition that happened so quickly, that the need went a little faster than we were actually ready to go with, right? So we had to hurry up and get caught up. But as a result of it, we still have a very thriving telehealth component to the services that we offer. We're still sending those test kits out, you know, and we have people inquiring about that mechanism all the time. The other thing that we've just noticed, however, is a need to, you know, going back to the cultural competency piece, making sure that we are approaching this knowing that not everybody has the same technical capacity on the other side. So because we're offering the telehealth, because we're offering these options in the digital space, we can't assume that everybody has access to a reliable internet, to the devices that they need to engage this way, you know, just to the wherewithal or the know-how in terms of how to engage from that digital space. So making room for that too, in the way that we roll this out and the way that we provide support on the back end.
Thank you. Yes, the technological component, which is something we often take for granted. So thank you for shedding light on that. Dr. Strader. Oh, I think you're muted, Dr. Strader.
I was thinking you're absolutely right, Tatiana. The lack of knowledge is a big challenge. In the clinic in ICHC, the lack of understanding about HIV disease and how much affects Americans is our patients just cannot imagine. In a lot of languages, there is not even the term for LGBTQ. There is no term for the pronouns, and our staff has no concept what the SOGI terms are, and I cannot count how many patients who come, refugee patients who come through and not knowing how to use a condom. I have to show them how to use the condom. I have 26-year-old woman who has been pregnant before who think that, oh, you cannot get pregnant if you have sex standing up. There is a lot of education that my patients need. And then I don't know, like there's also some assumptions that reminds me of the model minority myth. Like even our own providers in the beginning has some snap judgment like, oh, my patient's monogamous, they don't get STDs, or infidelity is a tragedy against the gods, my patients won't do that. So they don't, and also the parents don't believe that children can be influenced by their friends and acquaintances at school. So education is a big part. And then the positive end is kind of a sad truth, but it is helpful. A lot of my patients are so accustomed to being exposed to infectious disease like parasites in the camp, bacteria, viral infection. They are just less resistant to screening and testing, or even, and they are more receptive to vaccination and treatment. They would say, okay, like I want to get tested. I want to find out if there's something wrong, and I'll take medicine. And I will, like, talking about PrEP to them is a lot easier. But and then also I like that even though Ohio is conservative state, I don't know if I can say that, Cleveland and Akron are pretty progressive, and they are pretty multicultural city. We do have a lot of summer celebration this year after the COVID pandemic is slightly alleviated with the vaccination. We have Pride in the Valley, we have African American Festival, Asian Festival, we have Diwali. So there's a lot of chance for Dr. Rashid and his team to go reach out and talk about safe sex and talk about the HIV kit. And then, of course, we have a lot of support from our policymaker, and Akron, just as a city, banned conversion therapy on children, which is a big step. And the mayors, the health department, they are all very supportive, and they would send, health department would send staff to our events, and they would share, they would collaborate with us and other organizations for to do HIV eradication.
Thank you. You've highlighted so many great points, and one in particular that really struck me was the need for understanding levels of communication, in the sense of, as you mentioned, pronouns may not necessarily translate to the language of the patient. There may not necessarily be a word for a term that we may often use, but then also being cognizant of the possible lack of communication within the home. If parents and children are not having these conversations, if that is something that is not necessarily culturally appropriate, how to sort of circumnavigate that. So I appreciate you mentioning communication on various levels. Dr. Rashid.
Yeah, I'll be brief here. So I think low literacy, obviously, language barriers in general, and then cultural stigma is a pretty big barrier for us. I know from my experiences doing some outreach and talking to community members, it's really, really hard to even engage with anything remotely having to do with sexual health with our AAPI community members, immigrant community members, refugee community members. They don't even want to be seen talking about these sorts of things. And so it's hard to design messaging to promote engagement, obviously taking language barriers and low literacy into account, but trying to change these cultural stigmas around sexual health and HIV are extremely difficult to do, and that's ongoing. And always looking to the outside resources for, assistance and improvements that can be made in this respect. But I do think we are making slow progress, but it is going to take time for sure. So yeah, cultural stigma is one of the big ones, one of the big barriers for us. And I guess one of the major facilitators would be trust. And I touched on this earlier. Trust is huge in building rapport. It's something that will work against cultural stigma as well. So that's something solid that we have going for us at the moment that we're definitely using to our advantage.
Certainly. And I think you're clairvoyant, because this leads into my next question, my last question, actually. So I wanted to end this on a positive note. And again, if anyone has any questions, please feel free to start adding them to the chat. So my last question for each of you, based on your experience building trust within these communities, particularly those who have been or continue to be marginalized societally, structurally, what have you, of course, takes time and persistent dedication. And so what are some indicators that you're moving in the right direction when it comes to building rapport with these communities? I suppose these indicators could possibly inspire other organizations that are in the room so that they're aware that they're, again, moving in the right direction when they're trying to better engage these particular communities. Ms. English, I'll begin with you.
Well, Sister Love has been in our community for 33 years. So we do have a level of trust with the community just based on that longevity, but you have to work to continue to maintain that trust. It takes work, especially as people age and move out of the neighborhood and other folks are there. So it really it requires an ongoing effort to maintain that level of trust in the community. But I will point to our longevity as one of those factors that helps us in that area. In terms of the indicators that we're moving in the right direction, we have folks reaching out to us like Emory, Morehouse School of Medicine, CDC, about what our specific tactics or strategies are related to community engagement. When you have large healthcare settings asking you about your strategy for engagement so that they might employ or partner with you, then you know you're doing something right. We've done community research studies that has such large and effective engagement that the body that was paying for this huge research came back to say, hey, how did you guys do that? How did you get them to respond? How did you get them to get back with you? And it was simply because we're in the community. So we approach them as such. It's easy to show up in a community and say, hey, we have this wonderful research idea or this new product, and we'd love to, get your feedback or see how it works out on you. We'd love you to be a part of this. When in actuality, those folks should have been at the table when those things were being planned in the first place. They need to be put in places of leadership. They need to be put in places where they can help effectively come up with the solutions that we so valiantly show up with for them without including them in the conversation. So engaging them in spaces of leadership, giving them seats at the table, before we show up with our grand ideas in their communities.
Thank you. Thank you so much. Mr. Lira.
Okay, I agree with Ms. English that having people wanting to collaborate with you is a good indicator, and but also patients who refer other people. Like when I get people that, to me, that sounds like, oh, I did something good because apparently this person trusts me and is budging for me with other people. So that's another thing that is a good indicator that I'm being effective. And then the other thing is that sometimes they don't take the testing kit right then and there, or they don't get tested right away. But later on, they'll call. They save your card, and then so that's another good indicator. Maybe it wasn't the right time for them to get tested, but they remember me, and and kind of offer other things also has helped me. I don't know if like mental health services, like if somebody needs counseling, things like that. Sometimes they have more pressing issues with other things, immigration, stuff like that. They need an immigration lawyer. So sometimes if you help them with that, you kind of win them, and then everything else like kind of falls in place. And when they see you, they already know why you're there, and it's so much easier to talk to them because they trust you.
Thank you, certainly. Dr. Rashid.
I think for us, I think seeing our patients have discussions about sexual health or HIV, asking questions, generally just showing an interest in these topics, I think is a positive and is a good indicator that we're creating some type of positive change and doing something right, given the effect that cultural stigma has and the barrier that that represents for us here. So I think those are, positives that we can, that we having those conversations documented. Those are actual indicators that we use to determine if what we're doing is, on the right track. So.
Of course.
Sure.
Dr. Strader?
What was I gonna say? So the indicator, the most rewarding experience for me will be like, I'm big on relationship. So like Lewis and like Miss English says, like the patients bring their family back to see me. Like the patient comes, they trust the providers so much that they bring their friends, they bring their community members, but most importantly, they trust us to take care of their family. That's one great indicator for me. And then another rewarding experience will be their health improving. They look better, they feel better, and even if they learning, or they are getting accustomed to understanding medication adherence and chronic disease management, as long as they come back, that's wonderful. And then back to the trusting, like the thing, if someone would open up to me, like how they were tortured, they have musculoskeletal problem because they were bitten by the government, or they still have flashback from running knee deep in icy cold water, like things that they don't want to tell people. When they open up to me, I think those are good indicator for me.
Absolutely. Absolutely. Talk about building trust. That's incredible. Thank you. Mr. Wilson, last but not least.
Thank you. I think in regards to building trust, key things come to mind is consistency, authenticity, transparency. I think that's where it starts. I think that is one way that we started to build rapport with our clients, our participants. Another thing I would say is ask them what they feel, ask them what they're experiencing, ask them what could be improved. I think evaluating certain things kind of assist with evolving what our programs are. Remembering that these are people and not just a number or an objective. I think a lot of times if people come into a place and space and they feel as if they're just an objective, they're going to feel like, okay, you really don't care about me. You're just trying to get your goal or whatever the case is. So I think building the rapport with the person and building that comfort there really helps. Once you start seeing people coming back, you'll start seeing that they recommend their friends to come. Those are some of the indicators that that show you that we're moving into the right direction in regards to our programs. I do find that it is important that we amplify the voices that are usually silenced, and allow them to have their ideas and their voices heard and utilized in the community engagement aspect. And I think that's where you'll get the buy-in. So what I've experienced and seen is that those are the indicators, those are the key things that help build trust and rapport with our participants. And I think that is where success will continue to be found.
Thank you. On that note, does anyone have any questions? This has been a wonderful panel, and I appreciate these really detailed and impassioned responses. But does anyone in the room, in the Zoom space have any questions for our panelists? It's a bit quiet. I think that means that your answers were so detailed that that you've probably answered some questions people possibly had. But a last call.
I just wanted to maybe comment on one little thing that I heard Lira talk about earlier on. And this is about the stigma, especially among the Latino. I find it a very big barrier here. I'm in Baltimore. I'm sure those that are in Baltimore can also bear witness with me. Stigma on HIV/AIDS is much more than the stigma we see in other diseases like tuberculosis, like COVID, like I have not seen any stigma so big as that we see among the HIV/AIDS people. So whenever you talk about a test, people begin to worry about confidentiality, privacy, and all that. Quickly, don't let my mom know, don't let my dad, don't let my who know about this. And so my request, one time that we discussed this with the City Health Department, is to find more ways of readdressing the stigma. You know? So I was so, I heard what Lira was talking about stigma, the way it is treated. So that's something that I think we need to probably look for better. I mean, maybe other ways of dealing with stigma.
Yeah, and Miss English, go ahead.
I'm not sure if he was addressing it to one person, but similar to what Greg brought up earlier, having peer navigators on our system is part, or on our team is part of that strategy. We're always telling people that knowing your status is the first part, but there's life past that diagnosis, and we have the proof of it. We have proof of it by way of our support groups, by way of our Leading Women's Society. Listen, by way of this beautiful staff member who's been with us for so many number of years, that's here to be with you right here, right now. You don't even have to leave this room alone. You can get through this. So just preaching the gospel of, you know, life past diagnosis, because it's so real, and it's effective also at removing the stigma. Like other chronic diseases, it can be managed and you can live and thrive way past that diagnosis.
Thank you. I don't know if anyone else wanted to comment on that, on the burden of stigma.
Could I add that for me, what has worked is educating the patient, meeting them where they're at. If they say something that is not accurate, kind of like give them the right information, but and don't press them on getting tested. Like if they're not ready, I don't think it's a good thing. They'll come when they're ready, but just educating them about. I even to give stories, like sometimes telling them stories about other patients that you had without giving names, of course, helps them understand, because like we talk about, everybody has a different level of literacy and of language. And sometimes if you just spend a little more time with them, they'll get it. And if they don't get it once, but you keep like saying the same, if you're consistent on the facts, I think that diminishes the stigma.
Yeah, I'd like to add something as well. I think for us, definitely our messaging is really centered around letting community members know that it's okay to talk about sexual health, talk about their sexual health, letting them know that what they share is confidential, and that any questions or concerns that they have can be confidentially answered, and their concerns addressed in a way that's beneficial to all parties involved. And creating, and this goes back to creating an environment that normalizes these kinds of conversations, creating a clinic space that's a safe space for our community members, normalizing topics around this conversation, normalizing what we use on our forms and surveys that we distribute to patients. Basically, letting community members know that this is a reality. These are things that can be talked about and addressed in a positive way that ensures, their safety, their health, and can be done in a confidential way. Like that's been the focus of our messaging with respect to stigma, cultural stigma.
Thank you. That's incredibly important. And I appreciate everyone taking this time. I will, just because I think we're running a few minutes over, but it's just been such a great conversation. I do want to thank you all again for attending. For the panelists, if you haven't already, if you're comfortable with it, please feel free to put your email in the chat, just for those that may want to connect with you after this panel. But again, thank you all. And I hope that you all have a wonderful day. And thank you for engaging in this conversation so that we can strive to be more culturally competent in the ways that we engage members of our communities in HIV testing and prevention. So again, have a lovely day. Thank you all.
Thank you.